नहीं नहीं नहीं. Good afternoon, everyone. We'll just start in a while. We are waiting for Puri sir to join from NACO. Kiran, I think we can start the recording. Go ahead with the session and I'll check back on Puri sir again. Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is nutritional care of HIV-infected children and counseling for children and adolescents living with HIV. We have with us today Dr. A.K. Puri sir from NACO. He'll be joining shortly. And Dr. Anju Seth madam from pCoE KSCH and Dr. Kalpana Datta madam from pCoE MCH. We welcome you all for today's session. Kiran will quickly run through the pretest. Kiran, can we have the pretest, please? Thank you. Participants are requested to please attempt the pretest questions. There are 6 questions in all. Please scroll through your screen, scroll through all the 6 questions and answer the correct question. Kindly note the pre and post test questions are connected to your attendance. So please be with us till the end of the session and attempt the post test as well. We have another 5 minutes for the pretest. Participants are requested to please attempt the pretest questions. Meanwhile, Puri sir has joined. We welcome you, sir, for today's session and request you for the opening remarks. Puri sir, I think you'll have to unmute. Yes, sir.
Yes, sir.
Puri sir, good afternoon.
Good afternoon.
Good afternoon, sir. Sorry, we started with the pretest, sir, just to save time. Can you please give the opening remarks, sir?
That's all right. Okay. So, welcome all the participants and from SACs and ART centers. It is an important session. We'll be discussing about the nutritional care of the HIV-infected children and counseling for children and adolescents living with HIV. In today's session, we are going to discuss about the role of nutrition in care of HIV-infected children. Assessment of nutritional status and growth, classification of nutritional status of HIV-infected children, nutritional need, management of HIV-infected children 6 months to 14 years of age, management of children with severe acute malnutrition and supportive measures including micronutrient needs of these children. We will be also discussing in a brief about various challenges faced while counseling CLHIVs, child-centered counseling the caregivers, which is very important, and the child for lifelong ART, follow-up counseling for adolescents living with HIV, and challenges faced by ALHIVs. The most important thing is that when we have to declare the status of, at one point of time, we have to tell the CLHIV that they are suffering from what kind of disease and they have to take the lifelong medicines. Initially, they may not be knowing it, but it is a very tricky thing, and psychologically and socially also it is very important, and even that needs to be managed. So I wish all the success for this NDLS session. Over from my side. Thank you.
Thank you so much, sir. I now request Anju ma'am to please start the session.
Thank you, Shweta. Am I audible?
Yes, ma'am.
Okay, I think you will be doing the slides, right?
Yes, ma'am.
Okay. Good afternoon, participants. So today's session, we have two important topics covered. I'm going to take the first part, and this one's going to focus on nutritional care of children with the HIV infection. Next, please. So the important aspects that I'm going to cover include how to assess the nutritional status of children with HIV. How do you manage as per their status? How do you do a nutritional management of these children? Rest of the components are going to be discussed by Dr. Kalpana Datta. So next slide, please. Next, please. Okay, so as we are all aware, children are different from adults in the sense that they are growing, right? So everybody, of course, needs nutrition for maintenance of their body metabolism, but children also need extra nutrition because to meet their growth and development requirements. So there is a big interaction between nutritional status and HIV infection, in the sense that HIV infection lowers, as we are aware, it lowers our immune system. Therefore, once the immune system is no longer functioning optimally, our body is vulnerable to infections. And infections, various opportunistic infections, further affect the nutritional status of the child in multiple ways. One, presence of an infection leads to catabolism in the body, okay, thereby increasing the nutritional requirement. Secondly, because there is infection in the body, the appetite of the child goes down. Appetite is very, very sensitive indicator of overall health of a child, and infections affect the appetite profoundly. Thirdly, infections like diarrhea are going to decrease the absorption of the nutrients. Therefore, there is whenever there is in an immune compromised state, the child's infection chances increase, and thereby his requirement goes up, but what he's actually taking in goes down. Therefore, every infection is associated with a faltering of the child's growth or weight gain. Usually, if an infection is followed by an infection-free period, the body tries to compensate. So there is a period, once the infection has been taken care of in a healthy child, there is a period of catching up. So a child will have spontaneously an increased appetite, thereby he increases his nutrient intake, body makes up for whatever it has lost during the infection and comes back on track. However, in a situation like HIV, where a child continues to suffer from HIV, which anyway increases the basal metabolic rate of the child, and if he has recurrent opportunistic infections, the body does not have time for catch-up growth. Therefore, such a situation leads to a progressive deterioration of the child's nutritional status. Not only characterized by weight loss, there would be associated muscle wasting and deficiency of various macro and micronutrients along with their symptoms. And a poorly nourished child again gets more predisposed to further infection and further weakening of the immune system. Thus, it's a vicious circle. And this vicious circle is something that we need to break. If we are trying to provide a holistic care to a child with HIV, it is very, very important to break this vicious circle so that the child not only gets antiretroviral therapy, he gets all the associated requirements for a holistic improvement of the child's condition. Next slide, please. So first thing is, how do we assess nutritional status? That's the first step. Unless we know where we are beginning, we'll not be able to make a progress. Next slide, please. A few things are important. One, the medical officer, the nurse, or the counselor, anybody should do a quick dietary history of the child. The dietary history tells us how much is the child's intake. Is the child taking food from the various various types of food categories. Is there a good dietary diversity? As well as sometimes there are some taboos in the minds of family that this child has this infection. For example, a child will cough. Very often the families will say should not be taking banana or milk because it increases the production of phlegm. These are the kind of impressions that are there in the community. So what are their ideas? What are their misgivings? What are their food fads? What does child like to eat? And so a good assessment of child's diet is important because that helps us plan what kind of a counseling should be given to improve the child's diet. Next is evaluation of the child's growth. And here I don't mean only weight, we also mean the height of the child. We need to measure the height for a child beyond 2 years or length of a child under 2 years. We need to measure the weight. We also need to look at the mid upper arm circumference, and we need to evaluate a child's growth. Now, I know it for a fact that despite repeating it again and again, at most ART center, nothing is being done apart from taking weight. I would really urge upon all of you to please start taking height and length of the child part of your routine assessment of a child with HIV. Next important thing to assess would be the caregivers' practices and family food security. Again, what are their biases? What are their thoughts? What are their practices, food practices, and what is the socioeconomic status of the family? Remember, these families often tend to be impoverished and stigmatized families, and that can impact upon the food security. And finally, of course, if the child at present, at the time of assessment, has any opportunistic infections. Next, please. So this is a growth chart. What we recommend is for a child up to 5 years of age, we use WHO growth charts. And if you see this growth chart is for boys and girls. It is showing weight for age. And you can see there is a median green line of 0, which means the median weight. And above and below are lines. Above is 2 and 3 and below is -2 and -3. What is being shown is the Z score, or how many standard deviations below the median. 0 is median, -2 refers to -2 Z score or -2 standard deviation away from the median, and -3 line means 3 Z scores below the median. So this plotting actually helps us assess the child's nutritional status at one point as well as longitudinally. Okay, longitudinally by serial plotting. In a well-growing child, we expect that his weight for age, for that matter, we also have similar length for age, height and height for age charts. We expect that the child's parameters will remain between +2 and -2 standard deviation. And if we join the serial points on the growth chart, they will yield a curve that is parallel to the curves that are existing on this chart. So for one-time assessment, we are looking at a particular point on that particular day, and we expect a child to have a healthy child to have it between +2 and -2 standard deviation. And if we have a serial record, the curve should be parallel to the curves on this chart. So a serial record maintenance at an ART center is a very, very sensitive tool towards telling us about the overall health of the child. Next slide, please. So this is a very similar chart for height for age for boys and girls. And see, it writes length oblique height, which means till the age of 2 years, we are talking about length, and beyond 2 years, we're talking about the height. Again, I urge all the medical officers to please start taking length and height routinely in your clinical practice, because HIV does impact upon a child's not only weight, but also the longitudinal growth of the child. Next, please. Okay, so a very good parameter of wasting, a very good indicator of wasting is a chart, is a parameter known as weight for length. So what we are looking is, what is the child's weight as compared to the weight of the child of same sex and same height. So for example, if we have this, if you see, does not take in account the age of the child, but just the height or the length. So for example, if a child regardless of his age, has a length of say 90 centimeter, a boy with a length of 90 centimeter. If you look at this growth chart, can I use a pointer here? Is it possible? Shweta?
Sorry,
Can I?
ma'am. No, no, ma'am.
Okay. All right. So fine. If we look at say the 90 centimeter on the blue chart here, we would expect the child's ideal weight to be somewhere around 16 kg if I extrapolate. I'm not able to extrapolate immediately. So somewhere around 14 kg. So what we have to see is if the child's weight is say 12 kg and his length is 90 centimeter, it would compare this with the weight of a similar child for the same length. So one can plot on weight for length the same info and see whether the weight for length is like the previous parameters within +2 and -2 z-score, or is it below -2 z-score. If it is below -2 z-score, the child is said to have wasting. And if it is below -3 z-score, the child is said to have severe wasting. Okay, so if you want to assess wasting, then we must assess the weight for length. And in a child beyond 5 years, we assess BMI. But if we are assessing length for age, we are assessing for stunting. A child with height for age or length for age less than -2 z-score is said to be stunted. And if the same is less than -3 z-score, then the child has severe stunting. Okay. So next slide, please. So this shows what I had theoretically said. Normally, we expect any of these parameters, weight for age, height for age, or the weight for length. All these three parameters, when serially plotted, should make a chart which is aligned, which is roughly parallel to the lines on the growth charts that we have shown. If the curve yielded by the serial plotting of the child's parameters shows a flattening or shows a downward trend, that indicates this child's parameters are deviating from what is considered to be optimum for this child, and such a child requires urgent clinical assessment and remedial action. So this kind of a curve you will only get if you're plotting it serially. If you're not maintaining a serial record, you will not get it. Next slide, please. So based on our assessment, it's a good idea to classify the nutritional status of the child, how the child is doing. So this of course has kind of overlaps with some bit of pediatrics. This is the classification that we do. We teach all our students in pediatrics, and it's the same that will be relevant for assessment of children at our ART centers. So if a child has signs of severe visible wasting, severe visible wasting means that he has loose hanging folds of skin. These are very easily visible in the thighs, in the buttocks. The buttocks become flat. Normal buttocks are rounded. So flat buttocks with multiple folds of skin hanging, front of the thighs with folds of skin on the medial side of thighs, loose and hanging folds of skin on the upper arms, easily visible ribs. These are signs of visible severe wasting. If this is present, or a child has edema or swelling in both feet, or if this is a parameter that we have measured, weight for height, or in a child beyond 5 years, the body mass index is less than -3 z-score. Or if we have not measured weight for height, then if we have measured the mid upper arm circumference, if that is less than 11.5 centimeter in children up to 5 years of age, MUAC we use only for children up to 5 years of age. For children beyond 5 years, if it is the cutoff is 1.29 centimeter, and for children in the 10 to 14 years, 1.6 centimeter. So you can use MUAC, though MUAC is more standardized for children up to 5 years, but these cutoffs are also valid. So you can use any of these parameters. So if a child has any one or more of these parameters, then the child is classified as having severe malnutrition. That's the topmost box. Okay, and it's important to assess because children with severe malnutrition are very, very vulnerable to mortality, very vulnerable. If they get another infection, they tolerate it very poorly. And children with severe malnutrition are vulnerable to many metabolic disturbances, especially hypoglycemia, hypothermia, electrolyte imbalances, congestive heart failure. So it is very important that we recognize severe malnutrition in children with HIV. And this often happens when HIV is detected late in children. Okay, so if we are actually following up a child and he is on ART and is linked to your center, it is we hope that we will pick him up before he develops severe malnutrition and we'll give him proper appropriate care. However, if the child, say for example, is lost in care, he's not coming for follow-up, he stops his drugs, or he has not been picked up. Such are the children who are likely to come to us with severe malnutrition. And managing severe malnutrition is a medical emergency. So this is our first group. The next group is just we going from top to bottom. If a child does not have any of the criteria that match severe malnutrition, but has a reported weight loss, the family says that he is losing weight, or his weight for age, we have spoken about weight for length, weight for height. In column number 2, we are speaking of weight for age. If that is less than -3 z-score or less than -2 z-score, anything less than -2 z-score, or if there is a confirmed weight loss from the previous visit. Or same thing, if you're putting in a growth chart and growth curve is showing a flattening, all these indicate poor weight gain. So we actually go from top to bottom. This is how we classify illnesses in integrated management of neonatal and childhood illness. So if a child meets any of the criteria in the topmost row, then he has severe malnutrition. If he does not have any criteria meeting the topmost row, but has criteria meeting the number 2 row, then it is poor weight gain. If a child has none of these, that means his weight for age is more than -2 SD, more than -2 SD, and he's gaining weight appropriately. That means his growth chart is kind of parallel to the lines existing on the growth chart, then he is growing appropriately. Okay. So, and fourthly, if a child, in addition to HIV, has any other opportunistic infections, like especially long-standing infection like TB, persistent diarrhea, or he has, say, chronic lung disease, or he has an associated malignancy. Now, all these conditions further increase the nutritional needs of a child, and this should also be identified. So what we learn is, after doing a clinical assessment of a child, looking for visible severe wasting, looking for edema, and assessing the child's anthropometry and plotting it on the growth chart, we should be able to classify our children into these one or more of these categories. So a child may have severe malnutrition or poor weight gain or growing appropriately. And in addition, some children may have the last category of conditions with increased nutritional needs, apart from the top 3 categories. Next slide, please. So this you don't have to remember, but this is just an illustration of what are the energy requirements of children with HIV. In context with what we discussed in the previous slide, let's look at the top headings. So of this table, one in dark green. So first column shows the age of the child, and next column shows what children in that particular age group require. What is the normal requirement of that age group is shown in this chart. Normal kilocalories per kg per day requirement. Now, because HIV infection is there in these children, even if the child is otherwise well, growing well, and he is asymptomatic, just because he is HIV infected, ideally he needs 10% additional energy, because there is an ongoing infection in the child and there is an associated catabolism. If our child in addition has the poor weight gain, or he has other additional symptoms, the last column, number 2 column and the last column. So if he is HIV infected, along with that, he already has weight faltering, or he has conditions that increase his energy need. Remember, we spoke about chronic lung disease, persistent diarrhea, tuberculosis. Such a child's energy needs get increased by 20%. And this table just shows what it means for various age groups. And the last category If the child has HIV infection and also has severe malnutrition, this child actually requires very high energy. His energy requirements become actually 1.5 to 2 times. So 50 to 100% additional energy needs. So this is what these are needed as per the child's nutritional status classification. Next slide, please. So keeping this background in mind, how do we manage the nutrition of these children? Next slide, please. So first, let us see what children with severe acute malnutrition need. If we know this is our children with severe acute malnutrition, we must also look for, first they need a thorough evaluation by a pediatrician. Any child with HIV, if he has severe acute malnutrition, needs evaluation by a pediatrician. And especially we need to look for anemia. We look for evidence of other micronutrient deficiencies like vitamin A, vitamin D, vitamin C, minerals like calcium. Apart from a thorough nutritional evaluation, they require to be evaluated for various opportunistic infections. We need to evaluate, especially if the child was in the system, then we need to evaluate them for drug side effects. Is there something which is flaring up their symptoms, say adverse effects related to the drugs? What is the treatment adherence like? Because as I said earlier, a child with HIV who has been started on ART should show an improvement in the nutritional status. So if he is already in our system and shows severe acute malnutrition, we have to look for his treatment adherence. And also treatment failure. Remember, severe malnutrition straight away would put him in stage 4 of HIV disease. So we have to look for treatment failure also. But as I said, a lot of time these children, when they come to us, this is the first time they are captured. So they might actually be referred to you first time after being diagnosed with HIV somewhere else. Next slide, please. Next slide. So this slide is just showing what we can do. See, and I think there are several such slides. I will not go through the minimum through the entire block, but will broadly tell you what can we do. So to improve the energy intake of these children. So if we are looking at, see, there are 4 columns here. First gives us the age of the child. Rather, in fact, age is in rows here. And the 3 groups: asymptomatic children who require 10% additional energy, poor weight gain who require 20 to 30% additional energy, and severely malnourished children who require 50 to 100% additional energy. Of course, to actually calculate how much they need would require inputs from a dietitian, which of course are available at select places. All ART center will not have that. So that is all right. But what we can do at ART centers, where there is a nutritionist, this is easy to follow. And these guidelines are there in the in the technical guidelines, and one can go through them in detail. But I'll tell you the broad principles. 1, a child with severe malnutrition needs to be admitted. So such a child not only requires evaluation by a pediatrician, but HIV with severe malnutrition, because of all the associated problems, and not to mention most of them have very poor appetite initially, they actually need to be admitted. They need to have their electrolyte imbalance corrected. They need to have their anemia corrected. They need to be screened for infections and managed. And nutritional rehabilitation only actually comes in place along with these things. So such children need to be admitted because they need to be given therapeutic feeding, which provides 150 to 200 kilocalorie per kg per day of the weight of the child. So this you cannot do from ART center. But what you can do is you can manage the first 2 groups. And there are very simple ways of actually improving the energy intake of the child. And for example, if you are looking at, look at the first column, in a child who's asymptomatic with adequate growth, if you need to just give 10% additional energy, which would mean for a child of 6 to 11 months, would require about 60 to 70 kilocalories extra. This can easily be provided by adding 2 teaspoonful of edible oil and 1 teaspoonful of sugar. So whatever the child is otherwise also normally taking, and in fact, I think it's very important for the medical officers and the counselors to know what a child normal of various ages normally eats. Those guidelines are included in the technical guidelines. So you should know what a child normally eats, and you just by adding energy dense sources like edible oil and sugar, we can increase the caloric intake. The same thing in a slightly increased amount can be given for children who have an increased nutritional need or who have a poor weight gain. These children will require 20 to 30% additional energy, which in these children will correspond to about 120 to 150 kilocalories per day. Again, you can give the same oil and sugar twice a day, so that serves the purpose. Next slide, please. So the same way these guidelines are there, I don't need to go through them in detail, but you can see there are simple things. Not only adding sugar or oil, we can add bananas, we can add full cream milk, we can add some butter, we can add some slices of bread. So adding some additional calories, additional meals in between, and what the child eats in between meals. We actually are normal vegetarian diet is not very calorie dense. So these children can be offered initially small frequent meals. As their stomach capacity increases, they can take more meals, more quantity each time. So adding, for example, if we look here, we give 1 extra cup, 200 ml of full cream milk. If it is given with 1 teaspoonful of sugar, that will give about 160 kilocalories. That's just 1 cup will take care of the additional energy need. Next slide, please. Likewise, for all ages, the examples are given. Main idea is we need to add what the family is eating. If the family, what is the, if it's a family's normal food consists of, say, idlis and dosa, we can make accordingly. If it consists of puri or parantha, that can be done. So it's a matter of what the family is eating and just modifying it for the child. Next, please. Next, please. I don't have anything to say on the, we don't actually need to provide all these slides. It is just to give a general idea. Next slide, please. So what is really also important is, first, you assess the child's intake along with what the family is eating. What are their myths? What are their beliefs and false beliefs? Correct those. Along with focusing on energy, please focus on dietary diversity. By dietary diversity, I mean it is not only taking calories. It is also about taking adequate vitamins and minerals, which can be provided by making sure that the child has adequate daily helpings of fruits, vegetables, of milk and milk products. And if they're taking non-vegetarian food, then maybe taking egg, chicken, fish, etc. So more diverse is the child's diet, more likely it is to be balanced. Okay. These children should be given micronutrient supplements equivalent to 1 RDA. Most of the multivitamin formulations that are available would suffice. In addition, vitamin A supplements needs to be given every 6 months as it's available in the government schedule. This is, of course, being given by the government for all children. So vitamin A starting from 6 months of age can be given. This is given along with immunization at 9 months, along with measles vaccine. Vitamin A is given orally in the dose of 1 lakh unit. And for children beyond 12 months, we give oral 2 lakh units every 6 months. Okay, this is given every 6 months till 5 years of age. And that takes care of the vitamin A requirement of children. In addition, deworming should be done every 6 months after the first year of life by albendazole. And cotrimoxazole prophylaxis is very useful therapy, because not only does it prevent pneumocystis carinii, but also gives prevention against protection against malaria and other bacterial infections. In patients with the recent history of diarrhea, we would give additional zinc for 2 weeks. And as I said, encourage regular play. It's not only about eating, it is about holistic development of the child, age appropriate activities, interaction of the family with the child, administer routine childhood immunization that will further protect the child from infections. Next, please. Okay. Then, nutritional counseling, I think it's very, very important to cover. Unless the family is convinced, you'll never be able to do it, because this is something you're not going to do from the ART center. This requires convincing the family, needs convincing the caregiver regarding the need for additional food. I think one can use a growth chart very, very effectively to tell the parents, look, this is how your child's growth is faltering. This is what it should be. This is what it is. So what we need to do to improve. And then, when you're doing diet nutritional counseling and you're doing a nutritional intervention, follow up growth chart showing that the child is regaining the lost weight and that his growth parameters are stabilized or maybe even catching up, can be a very strong motivating family to see that, yes, with these simple changes, my child's nutritional status is becoming better. So this is a kind of a counseling, and taking the family along is very important. In addition, they also need to be counseled regarding safe and hygienic food preparation, storage. There are very small things like keeping the nails clipped, keeping the food covered, especially in hot and humid conditions, using fresh food. Simple things add a lot, because any infection, one episode of diarrhea is really going to set back the child. Next slide, please. So these are the keys to safer food. Simple. Keep clean, keep your hands clean, keep the surfaces clean, protect the kitchen and areas and food from insects, pests, keep them covered. Separate raw and cooked foods. Cook thoroughly. Cooking would actually kill a lot of pathogens like bacteria and viruses, which may sometimes be present in the food. So if we are heating them, heat them thoroughly so that the food becomes safer to eat. Next slide, please. Keep the food at safe temperature. So especially in areas where there is a lot of heat and humidity, it is much better to keep them in the refrigerator. And if there is no refrigerator, then the food should be freshly cooked and eaten. Safe water is very, very important. And simple things like boiling the milk or using pasteurized milk, washing fruits and vegetables, not using foods beyond its expiry date, small things, using safe water. All these small things go a long way. Next slide, please. So this is what I was referring to. Again, there in your national guidelines. And these are the normal recommendations for children. These are as per the infant and young child feeding guidelines, what children of normal age should be eating. It is classified for various ages till 5 years of age, and it just tells us what should the normal food of these children should be. I'll not go into the details, but I would definitely like you to go through this. It's there in your guidelines, and it's very important that this is what a normal child should eat, and what I have spoken about earlier, that they need to be given additional energy on top of this. So one can easily modify the foods given here to meet the additional energy requirement. For example, a child who is older than 2 years, we recommend he should be given family food at 3 meals each day. Also twice daily, a child older than 2 years should be given snacks. So what is important is here, we can very easily modify those meals by adding a bit of butter or oil. And if you're giving sweet, one can add sugar. Important to add either in the meals or as snacks in between meals, milk can be given. Milk is very, very nutritious. And if non-vegetarian food is consumed, eggs can be given as snacks or as part of main meal. Fruits such as banana, chiku, mango can be given as snacks in between the meals. So one can very easily modify the daily normal eating habits to give a more dietary dietary diversity, as well as to increase the caloric need. So go by the general principles, but make sure that the child gets adequate calories as per his status classification. Next slide, please. Remember, for a child up to 6 months of age, breastfeeding is the best way to help the child. Beyond that, we add complementary feeding, and complementary feeding has to be culturally relevant, and one would add as per the child's age. We'll keep on modifying as per the recommendations given here. Next slide, please. Okay, so once we have done a nutritional intervention, we need to follow up. So if a child is growing well, we need to just follow up in 2 to 3 months and see the growth, see the child, has the child's appetite improved, how much has the family actually modified the child's diet to as per the guidelines provided. Are they having any problems, any doubts? We need to sort that out. If the child is on ART, then we need to actually see if we need to monitor the growth and the weight of the child. If the child is gaining weight and he's doing well, we can follow up 3 monthly. But if the child is still not gaining weight, we need to reevaluate every 2 to 4 weeks and see what has happened. And in a child who has increased nutritional needs, again, such a child needs to be monitored more carefully. If the child is unwell and is showing signs of growth faltering and has recent diarrhea, these children actually need to be, if they're not doing well, if the weight gain is not there, they need to be reevaluated as to where is the problem. Is there an opportunistic infection? Is it that their family situation is such that they are unable to nurture the child? Or is it that the child's HIV itself, is he taking his antiretroviral drugs? So he needs a reevaluation. So such a child would require more frequent visits. So any child who's doing well, whose appetite improves, who's showing a steady weight gain, one can do a 3 monthly follow-up. Anything apart from that would require a more frequent visit and a re-evaluation. And as I said, a child with severe acute malnutrition definitely requires hospitalization. Next slide, please. So that is all from my side. And if there are any questions, I can take here.
Please give me 2 minutes, ma'am. Kiran, can you please give mic access to participants?
Done, ma'am.
Yes. Nivedita, ma'am, are you with us?
Hello, madam.
Oh, yeah. Yeah, that was
Madam,
a technical. Yeah.
We
ma'am,
have
please
seen
go ahead.
sometimes the family is caretaker. Sometimes there are orphans and like they are staying with grandparents and all.
Yes.
And so for such children, like nutritional support, anything is there, madam?
See, ART centers do not have provision for giving nutritional supplements. However, in many states, many states, there are provisions through the state government for provision of nutritional supplements for children, not only with SAM, but also with moderate acute malnutrition. Most states have those programs inbuilt. So through those programs, I think that licensing can easily be done. And these children, once they can be linked to this nutritional rehabilitation program, and supplements can be provided through them. As of now, ART centers do not have any provision for supplements, but a lot can be done by modifying the home-based diet. But yeah, I recognize that some of them belong to such impoverished families that they may require supplements, and they can be linked to the appropriate state mechanisms for the same.
Okay, madam. Kindly look into the matter, madam, because we have some people like that.
So it has to be taken up at the state level.
Okay, madam. Thank you.
That is important. Through your own SACs, arrangement can be made for supplements through the existing national programs, because most states do have programs. There are different kinds of supplements being given in different states, and they can be easily modified to meet the child's requirements.
Okay, thank you.
Thank you. That was a very relevant question, though. I'm glad you raised it. Yeah.
Any more questions from the participants? Please, you
Okay.
can unmute your mic.
Shweta, if there are any more questions,
Yeah.
they can be emailed to me. So, okay.
Yeah,
I'll answer.
sure, ma'am. Sure. Thank you
Okay.
so much, ma'am, for joining us.
Thank you. Thank you.
Thank you, ma'am. I now request Kalpana, ma'am, to please continue the session.
Thank you, Shweta. Good afternoon, everyone. We had a nice session just now with the nutritional needs and nutritional management of children and adolescents living with HIV. Am I audible?
Yes, ma'am.
So my topic is counseling for children and adolescents living with HIV. Next slide. Next slide, please. Now, what is actually counseling? What is counseling? Counseling is not a chapter, not a book, not a guideline, nothing. It is a process by which the person has to acquire this skill. So this is a skill. Whenever we are talking the skill,
मैम
ma'am.
वॉइस लो आ रहा है और बैकग्राउंड नॉइज आ रहा है थोड़ा सा
मेरा background noise आ रहा है?
Ma'am, maybe background noise cannot be avoided, but if you could speak a bit louder, that will be
Okay. Am I audible now?
Yes, ma'am.
Okay. So the counseling is a skill you have to acquire by the process of daily doing the counseling. And I think the doctors and the physicians and caregivers are the best counselor. And everyone can do the counseling, not only the doctors, even the nutritionists or the counselors who are dedicated counselors are there in the ART center. So why there are lots of issues and challenges while counseling the children and adolescents? Child and caregiver should be counseled. What are the things to be counseled? Challenges faced while counseling the child living with HIV. So the counselor will face some challenges, the caregivers will face some challenges, and the children or adolescent, they will face some challenges while counseling. Child-friendly practitioners should be there so that the counseling should be more receptive. Child-centered counseling should be done, and counseling the caregiver and child together so that they can have a good rapport and can have a good, they can follow the counseling process. That is for we have to counsel for treatment, preparedness, adherence, follow-up of counseling, especially when we are talking about the HIV issues. Other than HIV, there are many issues which should be counseled simultaneously while counseling about the HIV issues. Next slide. Next slide, please. So the challenges faced by the caregivers related challenges are frequent sickness, mortality in parents. So what happened? You counseled one caregiver and she had admitted in the hospital, she died, or also again there is some new caregiver should be counseled. So there are 13.7 million children are orphaned by single or double both parents due to HIV in the world. So it means so many other orphan children are there. So there may be frequent mortality and sickness due to we have to change the caregivers, and that have a great challenge. Then frequent changes in the attitude, belief, and habits of the caregiver. Sometimes the caregivers will change, and different caregivers follow different habits, different beliefs, different attitudes, different approach toward the child, and all those will be discussed by counseling. Child-related challenges. Dependency on the adults for the treatment, because depending on, of course, we are depending on the maturity level, we are dealing with the children or the adolescents. Poor attention span of the child, difficult experience by the child in communicating feeling of thoughts, poor physical growth, delayed developmental milestones, that to be addressed. Changing and understanding the child's age. So child-related challenges are quite tough, and it should be the counselor should be trained how to deal with the children, what are the issues to be discussed and how to be discussed, because children won't sit together at any place and for long time to listen to you and all. So they will have to take that in account while counseling the children. And home environment related challenges, higher chances of sickness, economic constraints, discrimination, stigmas, all those issues to be discussed while counseling. Next slide, please. So addressing challenges by supporting the child and caregiver through sensitive and caring counseling. So first thing to be taken care of is the empathetic attitude, sensitive attitude, and I would rather say the friendly attitude toward the caregivers and the child, so that you can support them while counseling. Counseling should be depending on, it should be, there's no protocol for counseling in particular children as such. You have to tailor your counseling according to the child's age, developmental status, the maturity level, understanding level, and the social, sometimes socio-economical background, sometimes the the educational background of the child or adolescents or the parents, and of course the treatment and its adherence and all. So you have to have a planning for particular session for the particular child, because you cannot generalize the counseling session for all the children. The children's need may vary according to their age, developmental status, HIV disease, socio-economic background, or educational background. So by adapting counseling changes needs, you have to make a plan. I have to discuss these are things for this particular patient. So first you have to identify the issues. Then you have to identify the issues in the children, as already discussed, in the caregiver and the home environment. Then you have to prepare ourselves for counseling and have a session. Identify the primary caregivers with the primary caregiver, because sometimes that primary caregiver may be sick, because usually we know the vertical transmission is common in children. So most of the time we see the mothers are positive and they might be sick sometimes. So you have to have one second caregiver as a backup, because my primary caregiver may die, may have a sickness, may be admitted in the hospital. Then you can have take the advantage of the second caregiver. Next plan. Next slide. So how to create a child-friendly ERP setup? It's very important before counseling, because you have to have a good environment where the child can have a good, good confidence, and then have a fearless attitude toward that. They can be free in that center. So it should be, next slide please. It should be lots of child-friendly in the environment should be child-friendly. That means lots of pictures and drawings and arts, comics in the walls, and plays and toys and small chairs and all those things. It should be comfortable for the children. For the environment is comfortable for the children, and you have to take care of the child. Counsel caregivers to support children. So how to make the center child-friendly? Counsel children to cope up with their infection, look after their health. Caregivers to be counseled and provide the comfortable environment, which is trained like a child's environment. Means we have a colorful walls, you can have paintings on the walls, different comics characters or the flowers, animals, and you can have a small toys. You can have a small chairs for them, and all this will attract them, and you can counsel in such situation. Next slide, please. And as I already said, separate room for counseling, small chairs, drawing papers. You can, because while counseling, you might have to draw some characters. You can counsel with showing some characters, and sometimes drawing some cartoons. So if you keep all those things, and you can ask them what is your problem, or you draw your thinking, you can understand the children's problem. So you always get ready beforehand while counseling, story books, games, toys, and the things which will be displayed like different fruits, vegetables, flowers, and all, so that it will. And of course, there should be a paper and pen and blackboard and chalk pencil will be there, so that, and it shouldn't be too high. Otherwise, baby won't see in the up of the wall and all. It should be in the child's level, eyes level. It should be in the one corner, so that they can draw. Even you can draw and teach them and counsel them, and they can draw their own feelings, own stories, own creations. Next slide, please. Next slide, child-centered counseling. So what will you do? First, you have to make a rapport with the child. So it's very important, not only the children, even in the adolescent, we say rapport. So how to make it a rapport? There's a gather approach. GATHE. We said the gather approach. Gather approach, G for greet. So hello, Ramesh. How? Good morning, good afternoon. So just greet him, ask him, tell him, H for help him, E for explain, R for return. So this is a gather approach we follow in, especially in adolescents. So first, the rapport building should be there, and you have to spend time for rapport building. You can greet him. You can ask, "Oh, what is the color of shirt? Who bought your shirt? Oh, you are looking so good in this color." In this way, you have to make a rapport with the child, and then ask the caregiver, the relation with the caregiver, with the child. It's very important to make a good environment by creating a good rapport. I mean, all three. Focusing on the child's needs. So again, it should be counseling should be individualized. You have to think of what is the need of each particular child. So what is the age, what is the weight, what is the maturity level, developmental developmental delayed or not, which modalities of development is delayed, whether the cross motor or the intellectual, or there's a cognitive failure in this particular child. What is the background of the child, socioeconomic background, and what is the educational background of the child? All those things to be focused before making the counseling process start. Tailored to the child's physical and psychological development. As I already said, building the self-esteem, respecting the child. And it's very important, each and every person, we expect respect from others. So if you pay respect, you will return respect. Similarly, we should respect the child also. They are very emotional. So you should not, hey, come here, sit there. No, please come here, please be seated. In that way, if you pay respect, they'll be very comfortable. So always give some respect to the child also, and they will help to make them their self-esteem. Next slide, please. And whenever you're talking about the child, you always take care of the caregivers also. Take with the caregiver, the help, and you have to talk with the child. Then only it will be very comfortable. Child will feel comfortable that my mother, my known person, father, whoever the caregiver has come, is with me and supporting me. So that will give a good relationship. As I always said, rapport building, greet the child and ask, why have you come in this center? So you just make a story, or tell you, just ask him why he has come. Did you take the medicine today? Did you have a bath today? Did you brush your teeth? All this just non-formal questions you just make him, and so that he will feel very comfortable, and that way you can build an rapport. Next slide, please. And you always, counselors should have a patience. Always keep patience and have a capability of listening properly. Don't interfere when he's playing, he's telling something. So it's very important to play. Sometimes what we do, whenever the child starts telling, I'm having this problem and that problem, we watch here and there. We were busy in writing prescription. We are busy in talking to someone. No, don't do this. These are the don'ts. Always listen properly, patiently, give some positive nods when he says some okay, yes, acha, and tell me more. In that way, he will be encouraged. So this is the positive listening, and always pay attention what he's telling, how he's telling, whether it's painful when he's telling, you just watch his expression, watch gesture, watch his movement, and you can get some idea whether he's in distress, whether he's happy, whether he's in pain or not. So it's very important to have a good listening capability. Next slide, please. So again, same, the recognizing and acknowledging the emotion. You have to watch properly, intently, while he's talking, while he's coming, while sitting, expressing his own problem, what he wants to say. And you can just, if he's having pain or some difficulty, you can empathize. Oh, you're having this problem. No, when I was young, no, I had a knee problem that time. I took medicine, I went to hospital. So you make a story and you just make him comfortable that you had the same problem and the other person, when their kid and having the same problem. So he will be very free and happy that that nothing fearful over here, and he will have clear conversation with you. So it is better to empathize, not to sympathize. If you say, I have a pain, oh, you have a pain. No, acha, this is the pain, okay. And other children also having pain if it happened that. If you have this problem, you can have this. So you just empathize with the children and try to understand what he wants to say, what he wants to communicate with you. Next slide, please. Acceptance and non-judgmental attitude is very important. We, the elders, the seniors, always we are judgmental. We always think, oh, he's bad. He's coming from this. He's very rude. He's very inattentive. He's very rough. He's very not paying respect to seniors. Don't be this. It just counts. See what is, and accept if he does something. He's may having some attention deficit. You may have some abnormal behavior. You might have some tics. Accept that. Sometimes you may have to ignore that. So while talking to the child, you always ignore the bad thing and highlight the positive. If he, when you say, please visit it, if you say thank you, oh, you're so nice, you know the manners, you know when if anyone senior says sit down, you know you have to say thank you, just appreciate. So what will happen? He will get the confidence, and it's very important to know what he is going to tell and what is he telling. Like you can ask. Don't ask close-ended questions. Have you eaten rice today? He will say yes or no. No. You ask, what did you have in the morning? What did you have in the meal? So this is an open-angle questions we always ask, so that he can talk and he can be very freely. So always take the child in confidence and help to take the decision. Suppose you are giving the drugs counseling. So you like to take a liquid or solid. If he says both, okay, would you like to take the syrup or tablet? Okay, a syrup will a bit, you know. So if you take with them some food, it don't feel better. So let them take the decision. But you give all the options and explain the things so that they can take the decision. So it's make them empowered to take the decision. It's very important. Next slide, please. So again, questioning and paraphrasing is very important. Don't do this. Just inquire what is need, what is the need of the child, and what is the importance of the child's growth, what is the importance of child's nutrition, what is the importance of the taking the drug properly. All those things you have to ask. You know, if you take the medicine, what will happen? You will be good, you will be strong, you will kill the infection, depending on the maturity level, of course, and depending on the disclosure, you have to talk the things. Don't make any story. You just ask him, what is the problem? Why, why have you come? Why your mother is brought to me? We will discuss, you have to take the medicine, you have to take the good nutrition, you have to take the vaccine, you have to play, you have to go to school. Or if you're adolescent, of course, then you have to talk to the adolescent in a different way. So it's very important to listen and paraphrasing answer the child's narrative somewhere. So don't make your own narratives or own story. Whatever he has said, whenever a child explains something, you take it from it and, okay, you mean to say that this, you mean to say that. You just take it and explain again to him so that he understands what I have said, the doctor has understood or the counselor has understood. And again, he's here to help me. Next slide, please. So counseling the caregiver and the child for lifelong learning. Next slide, please. Now we'll concentrate the different aspects of counseling. The first aspect of the counseling is because of the HIV infection. So for the infection, counseling will be preparedness, adherence, follow-up, disclosure, and all those things, the follow-up, looking for the side effects and all. Then of course the counseling for the nutrition, counseling for the vaccination, counseling for the growth and development, counseling for the responsive parenting. So there are different aspects of counseling. Now I'm talking about counseling regarding the HIV infection. So first, if the child is older enough, maturity is quite good, developmentally normal, then you can say, you are having some infection. So disclosure. Before preparedness is very important to disclosure. How we will disclose? Depending, and it is a gradual process and the partial disclosure at a time, depending on the maturity level and age. So it's very important if you disclose or if it's not disclosed, then your counseling will be different. It's very important whether you disclose the disease or not. Then the counseling for the preparedness counseling means you have to take the medicine daily for lifelong. It's very difficult to digest. So similarly, we have to prepare them. This is like you take the medicine diet daily, you take breakfast daily, you take the milk daily, you are strong to grow, to play. Similarly, you have to take the medicine daily. So you have to prepare the child, not only the child and the caregiver and the other family members for the preparedness of taking ART or accepting the ART. Then of course, after the preparedness, when they are agreed to take the ART, then after taking, you have to counsel the adherence issue. Why it's important to adhere with the drug. You have to explain it either by the drawing or the cartoons or any storytelling. And so, or you have to give the tips to adhere, how do you adhere. These things will be counseled. And of course, after adherence, follow-up counseling is very important. And you have to follow-up with the counsel about the, I'll discuss about the follow-up counseling. Next slide, please. Still voice is disturbing. Am I clear? Hello?
Yes, ma'am.
Okay, no, someone's written voice. So treatment preparedness counseling. So it's a very important issue because not only the ART baby has to take, if baby is less than 5 years and all then again, the cotrimoxazole, if baby is having tuberculosis, then anti-tubercular drugs with pyridoxine, there's a quite a huge number of pills has to consume. So it's very important to prepare them to take the drugs. So you have to explain that this is a medicine you have to take lifelong. So if you say in the state way, this is the medicine you have to take whole life. This is very rude and very cruel. But you say, you take the meal, no, you take the breakfast in the morning and the lunch and all. We take food. Everyone we take food daily for lifelong, so that we will be healthy. We grow. We have a power. Similarly, you have to take this medicine lifelong. So we have to counsel in that way. They can accept the drug very well. And it's very important. If we did, like, you should not miss the breakfast. No, your mother didn't say that you should not miss the breakfast. If you miss the breakfast, you will be weak for whole day. And breakfast should be very robust breakfast. Similarly, you say don't miss the drug. If you miss the drug, the germ will be very powerful. So it's very important to take the adherence counseling is very important, and how to be a good adherent. We have to get the counseling. It's very, sometimes if we have seen many cases in children, a mother gave the tablet, baby asked to swallow, baby swallowed. As soon as mother is turned on the other side and doing something, and they used to spit it out. Or sometimes they used to vomit. But the parents thinks that the baby has consumed the tablet, so they think that it's given, tablet is given. But no, if it is the baby vomits within 30 minutes of taking a tablet, that means it has not done, it is not been absorbed. You have to do this thing. You have to, the counselor has to tell voluntarily. Otherwise, there will be poor adherence. So it's very important to teach them the tips how to increase the adherence. You can say, you can give a clock, you can give the alarm, you can have a marks in the calendar, or anything they can have. It can have innovative ideas for the good adherence. All those to be explained. How to increase the adherence and what is the importance of adherence? If anyone realizes the importance, they will be adherent. It's important to give the importance of adherence by different modes, or by, different modes means by pictures, by storytelling, or anything, any cartoon playing, like you can play a cartoon. One is a teen, one is the fatty boy, and the person who is healthy, he's taking the regular medicine, and he's thin, he's not taking medicine regularly. So healthy boy will beat him with the thin boy. In that way, you can make a story and can show it in a cartoon or any storytelling books or any drawing. So it may require several sessions. I cannot, they may not conceive or cannot understand, cannot accept, cannot digest the things that you have to take the medicine lifelong. So you have to take 2 to 3 sessions, and it all depends on the maturity and acceptance of the child and the caregiver. So this major difference between the preparedness counseling for adults and children. So children are dependent on caregivers for treatment. Counseling for children includes the caregiver also. So you have to counsel the caregivers also. You wait till baby is to swallow the tablet or swallow the syrup, because we have seen many times mother give the tablet to the baby and ask to swallow, give the water. As soon as mother done or went away, they used to throw it out. So it's very important. Watch till they swallow the drug. That should be counseled. And of course, if there's a they used to vomit because of the taste or because of the smell, you can mask it by giving some good food or the favorite food for the child, and can give it with the tablet or syrup so that they can swallow it and digest it and may not vomit. And sometimes you might need some antiemetic for the vomiting every time they vomit. So you can give them antiemetic before 15 to 20 minutes, then you can give the drug and can ask them parents to watch. So these things, tips to be taught to the caregivers. So caregivers also to be counseled how to increase the adherence. Next slide, please. Next slide. The counseling of the caregivers. I've already said it is very important who is the primary caregiver, Who is the secondary caregiver? What is the status of the primary caregiver? With the primary caregiver herself is sick or HIV positive, especially in case of vertical transmission, the mothers are positive. So in that case, mother, what is the status of mother? Whether mother is adherent or not. If mother is not adherent herself, they won't be able to make the child adherent. It's very important what is the adherence issue, what is the understanding of the caregiver, and who is the primary caregiver. Always check one backup, one the secondary caregiver, grandma, maybe auntie, maybe any other relatives. So always take a one secondary caregiver also. Give the important, teach them the importance of taking ART medicine as you are teaching the child also. Similarly, you have to teach the caregivers also what is the advantages of ART, what is the limitation of ART. We don't have much luxury to have the drugs, like if it's not working, we will have this drug, if that drug is not working, we have a third another drug. In the, all the side effects and all. So it's very important to teach the caregiver that you have to be very adherent. The compliance must be good, and otherwise you don't have that many option on the drugs and ART, especially in children. So it's very important. If whatever the drug is given, it should be taken very seriously. And why we are giving the lifelong treatment? What is the importance of whether it's all those things to be taught to the parents or the caregiver. Then only they'll also follow the rule. And of course, you have to make them aware what are the side effects, how to identify the side effects, how to, everyone is having the Android phone and the phones and all. So you ask them to take photographs of that if the baby is appearing any rash, any sort of a problem they are appearing, suppose any abnormal movements, abnormal behavior, you can do the behavior video. If any rash is there, you can just take the photograph. And when you come to the caregiver, care providers, come to the ART center, you can show it. So these things to be taught to the parents so that the adherence will be good. Then again, teach them how to tolerate, how to adjust, how to take this, the child's positivity. It's very important because the parents feel very guilty. I am positive, so that my child became positive. It's very important. So how to deal with this, their agony. So you have to remove their agony, their sorrow, by giving that, okay, if you take care of this, if you can give the medicine regularly, if you can take care of the health, the vaccines, the growth, nutrition, and if you follow the doctor's advice, counselor's advice, the baby can be normal and can have a normal growth and development. So you have to teach each and every steps about the HIV. And sensitize the caregiver about the disclosure of HIV status. Because it is very shaky for the parents to say that you are positive to their own kid. It's very important how to disclose. So you have to teach the caregivers. It should be a partial disclosure. First, you say you have an infection or you have a disease. Then you can say the infection. Don't name the HIV depending upon the maturity level. So you have a germ or infection in your body. For that, you have to take the medicine. Then they can disclose, or they can take the help of counselor to disclose. So it's very important to teach them, sensitize them how to disclose the HIV status to their kids. And next slide. Next. So we know there are 5 steps in preparedness counseling: assist, advise, arrange, and agree. So these are the 5 we follow everywhere. This is the 5 A's rules. What do we assess? Assess the knowledge of the HIV status. What is the knowledge? So first you say, do you know what is HIV virus, how it spreads, what does it cause, what will be the consequences if we won't treat HIV? All those you just know how much they know. Then give them that according to their understanding. If there's some beliefs, like we have seen many children complaining, their stepmothers throwing the plates while giving the food, serving the food. So you have to say this is a disease, how it spreads, what is the mechanism of spreading. It's not, if you touch the child, it's not going to spread. If you take the same towel, it is not going to spread. We have seen they have isolated the child, they're keeping the child in a separate room and all. So these things are this understanding. If there are any misbeliefs, is any myths about the disease, you have to remove all those myths and beliefs. Then potential barrier to adherence and their social support system. So you have to identify what is the status of the caregiver and the child. What could be the barriers? Like we have seen many times, mother ask the father, okay, get up from the bed in the morning. Please get up, please get up. He asked her husband, and say, okay, you give this medicine to the baby. I'm going to wash my burden to another house. She might be a maid or the cleaner from the other house. She might go early in the morning and she will deliver her own responsibility to the her husband or the granny or any other person. So that is the barrier, because they go on changing the caregiver, and they won't realize if you change the caregiver, and then there may be chances of lack of compliance. There may be a poor compliance. So it's important to know whether she's working lady or not. If she's working, what is the timing of working? What is the mode of working? What is the what does she do all the whole day? These are the things you have to know before counseling about the adherence. It's very important to know the barriers and how to overcome the barriers. You have to take the help of them. You cannot remove the barriers from this side. So you have to take their opinion how to break the barriers to increase the adherence. So as you have to assist. Then assist child and care independent treatment and adherence plan. So you can assist them by how to increase the adherence. Like you can say, okay, keep a alarm in the clock, or you can mark in the calendar, or you keep it in the keep the brush and paste if you take early in the morning after taking the brushing the tooth and having something, then you take the medicine. So you can give them some tips, or you can ask them to have innovative ideas whether by which they can increase the adherence. So you have to assist their plan to increase the adherence. Then advice. What are the advice? There are many things you advise how therapy works. It needs lifelong therapy. It needs good regular adherence, regular follow-up. If adherence is good, they will think, okay, I'm going and taking the medicine. I'm taking the medicine regularly. There's no need to go to the ART center. That happens actually practically. But you have to emphasize that every month, at least every month when baby is okay, then you can come after 2 to 3 months, because there's an increase in weight. So when baby is younger, then the rapid gain weight, then of course there is some slowness in the growth in the mid-childhood, then again the pubertal phase, there is sudden growth. So if there is an increase in the weight, the dosage schedule will be changed. The number of pills might change. So you have to give the drugs according to the weight, and that drug might change. So if the baby does not come and then you take the, weight was 10 kg after 1 month, 10 kg after 2 months, 3 months, 10 kg, you go on giving the same medicine, it will be below the level. So that will cause the resistance. So it's very important to ask is the parents, tell them that the importance of bringing the child to the ART center for other follow-up, not only the growth, only developmental milestone, vaccination, other nutritional status, and other drug adherence should be checked. So it's very important to follow the doctor's advice regularly. And it is very important to say, if you say 95%, they will do it in 90%. So every time you will say it is 100% adherence must be there, so that they can have at least 98% adherence. It's better always to have 100% adherence. Then arrange. You have to arrange what investigation baby should have, whether baby should vaccination. You can arrange someone to get it vaccinated if there's any vaccination failure. If there's any investigation there, if baby is having some other problem, suppose baby is having convulsion or having some respiratory infection, or you need some expertise, you have to arrange the referral, which department, which doctor they will go for this medication. So it's very important to arrange everything for them, and so that they can get all the appropriate care. Then agree. Again, agree, child and caregivers both understand that and accept and agree to the formulated treatment. So they have to agree, okay, I'll take the medicine, I'll take the pills, or I'll take the pellets, or I'll take the syrup, or I'll take the tablet, depending upon that. So they have to agree, and they have to agree that I'll keep the drug, I'll take the drug regularly, I'll take it for lifelong, and I will keep it as much as possible for the 100% again. So these are the process we have to follow while counseling. Next slide, please. What, when, how, who, about the recommendation. It's very important. What drug to be given? That's very important. What drug? So sometimes we have seen as the acceptance of syrup is not good, whether you give the syrup or you give the tablet or give the pills or pellets. Sometimes they take the pellets, and you have to explain how to take the pellets. We have seen the caregivers giving the pellets by opening the cap. It should not be open. They are taking the cap, they are swallowing the tablet with the cap. So you have to teach them how to take the pellets. It's very important. There's a videos available and it is circulated to all. You know how to advise the caregivers to make the pellets, and just open it taken a plate or katora so that it won't spill over on the floor, and then take some food, the soft food or mashed food, and over that you have to open the capsule and drop the or the plates. Otherwise it will be spilled over. So it's very important to teach them how to take the plates, because they will, if there's 1 and 2, it is like a mustard. It is like a mustard seed. Size is a bit bigger than mustard seed. So what will happen? It will may go out of the plate. So they will think, oh, 1, 2 is dropped. So what? A rest is there. But they won't realize the dose has decreased. So these things to be explained, what to be taken, how to be taken is very important. Explain that a dose must be repeated if the child vomits within 30 minutes, because it is not absorbed in the gut. So make it sure. Always you have to voluntarily counsel that. If medicine, you give the medicine, let them swallow, see baby has not vomited within 30 minutes, then you leave the child. Otherwise, as soon as mother will leave and we might have a vomiting, and mother won't realize that baby has vomited, and that will be the compliance will be poor. Then a specific way to be taken. Again, the time is very important. We have to know that it's a child's routine, school routine, the extracurricular activities, then the sports time, everything in the child's daily routine must be explained very nicely. Then you have to adjust the medicine according to her or his routine. Because if you change his routine according to the tablets time, it will not going to persist. So it is very important to know what baby is going to do in the morning, then attend, then what to do. What will you do after 10? When will you go to school? After coming to school, what will you do? So you have to know the total 24 timetable, and accordingly, you have to arrange the time when the medicine to be given. And provide details on how to be given. When medicine is given or taken. Tablets can be halved as they are sport tablets. So as the counselors or the doctors will explain, the tablets to be taken exactly same. You don't have to do of her own or of his own. Because if you say some tablets are, if you if you break the tablet, the efficacy might be lost. So if the tablets should be taken in toto, it should be taken in toto. But if can be crushed, can be halved, then you can. And like in the pellets, it's always asked to open the capsule and take out the pills. Otherwise, they used to swallow we have seen the patient swallow the whole capsule at a time. So it's very important to explain how to take the tablet. A reminder should be given 15 to 20 minutes before the time, like the alarm clock, and everyone is having the mobile where everyone is having the alarm. So they can give a reminder before 15 to 20 minutes before the timing, exact timing. So there may be two alarm, one for the reminder call, one for the taking the medicine. So that will give the reboosting of the awareness. Then who will administer is very important. Always, sometimes we have seen the mother says, no, I'll take the medicine. I'll give the medicine to my kid. But when practically we see is the elder sister is giving the medicine. So it's very important to identify and be very specific. You have to ask the parents. If you are telling me that you are going to give the medicine to your kid, you have to give the medicine. Don't let it to be done by others, because we have seen in the practically, when mother is busy, she will ask her elder daughter, okay, please give the tablet to your brother or your sister. So that should not be happening. If the elder sister will give the medicine, you will counsel the elder sister only. So this is very important. Who will administer the medicine and when will administer the medicine? Next slide, please. So it's very important that 5 A's and who, what, when, and how. Then you have to prepare, teach the caregivers and prepare the caregivers that this tablet can have some side effects, which are the minor side effects, maybe the moderate side effects. When you see the major side effects, they should identify. So if there's a bit of nausea, headache, abdominal discomfort, and you can have some home-based care like abdominal discomfort, okay, you can take it in the after stomach, after some food, don't take it in the empty stomach, no. But you can give some medications if there's a headache and vomiting and all. But if there's a severe vomiting, severe headache, they should bring back the child to the ERT center. It's very important to identify the mild, moderate, and severe side effects of the drug. Next slide, please. Adherence counseling. Why it's important to adhere with the drug? What is the importance of idle suppression? What is the importance of non-adherence? What will be the consequences of non-adherence? These things to be explained in each and every time. Okay, this is already explained. Next slide, please. So common barriers of adherence, what are the barriers? So you have to identify the barriers, and that may vary with the child to child. And it may be a very specific child. It's very important to identify. There's a common factors. There may be child-related factors as they have to depend on the adult. They maybe liking and disliking, the smell, the taste, the color. So there may be emotional issues. They don't like to take the medicine. Using medicine to manipulate adults. Sometimes they can feign that they are taking the medicines. And of course, there are other infections might be there or other medication might interfere. So these are the child-related factors. But there may be other factors specific to the particular child. Now, caregiver-related factors, knowledge and understanding the treatment and its implication until and unless the caregiver understand clearly what is the importance of giving the medication or taking the medication, they are not going to be very compliant. So it's very important to teach them and make them understand what is the importance of taking medicine. If there's any misconception regarding treatment, if someone might have heard, if you take this medicine, you will be you will lose your hairs, you will be bald, something like that. So if there's any misconceptions regarding treatment, you should remove that. And some health beliefs, if there's any false beliefs or false conception, you have to remove that. What is the daily routine of the, as I already said, you have to know the daily routine of the caregiver's nature and timing of the job that may interfere with the adherence. And what is the attitude towards the adherence? What is the repeated change in caregivers' relationship with the child? It's very important. And you have to identify very beginning at the beginning, then only have to start counseling. So it's very important to identify the caregiver, the characteristics of the caregiver, the relation with the child, what is the daily routine of the caregiver, what is the attitude about the drug, medications, treatment, and adherence. All those things to be assessed, then only can counsel the caregivers. Next slide, please. What happens if there is no follow-up counseling? So the counseling should be done in each and every visit by counselors. When there's a scope of counseling by nutritionists, they will do, and the doctors. I think the doctors are the best counselors. So every visit you must counsel about something. And if, that is the one important thing. If you get any good thing, in any way, any good thing, you must appreciate. And that will give the booster effect. And they will be more adherent. Caregivers will be more confident. It's very important. Everyone needs appreciation. So don't lose any moment, any opportunity to appreciate the patient and their care. It's very important aspect of adherence. It's your child is having CD4, such a good CD4, such a good low viral load. That means you are doing fantastic job. You are taking your child very nicely. You are a very good mother. So she will feel very confident and she will do much better. It's very important while follow up the counseling. They always appreciate if you get any opportunity. If there's any mistake mother has done, any failure is there, don't discourage her. But you try to sort out the problem, why it is happening, and try to remove that barrier. It's very important. So what happens after taking medicine for 1 to 2 years, then they become fatigue. I'm not so long I'm taking medicine. I'm not going to take medicine anymore. I'm feeling tired of taking medicine. I'm feeling bad. Why others children are not taking medicine? I'm taking medicine. All those things may crew up in the subsequent years, and baby will feel tired of taking medicine. Oh, I'm tired of taking medicine. I'm tired of going to ERT center. I'm tired of getting all those stuffs from the counselors and doctors, they might say. So it's very important, all those things to be tackled very sympathetically or empathetically. And they have to be taken in your confidence to teach what is the importance again. So like I used to give, I'm having a defect in my eyes, so I'm wearing my specs. So you are having some problem, you're taking medicine. So it depends upon whose problem, what, and that to be removed by medicine. Our aim is to be healthy and hearty. So if you want to be healthy child, you want to be healthy adolescent, you want to be healthy adult, you have to take medicine. So in that way, you have to counsel And you have to see the follow-up counseling. Is there any adherence fatigue is developed in the children or not? If you see any adherence fatigue is developed, you have to remove that. Okay, next slide, please. Disclosure. Now the patient getting impatient. Yes. Next slide, please. Disclosure. Yeah, sometimes when they become impatient about everything, because this is the common attitude in the children. Even if you cook something and you're taking time at the home, and they'll be impatient. How long will you cook? When you will give me khana? Similarly, if they're taking the medicine for the last 2 years, 3 years, and they will be fatigued. They will be impatient. They will have, oh, I'm not going to take medicine. I'm not going to listen to anyone. So, but that to be tackled, that to be counseled, and make them understand what is the importance of taking medicine. Type and timing of closure. So now disclosure is very important. One of the important aspects of the counseling in children. First, we will start initiating disclosures. Very important. So 4 to 6 years we'll start disclosure. We started, and how we'll say, okay, the child is very curious why I'm taking medicine. I'm not ill, but others are not taking a medicine. So you have to understand, you have to teach them that this is very important. You have to take the medicine because others will be sick. You are well now, you are healthy now, but if you won't take the medicine, you will be sick after 15 days. So for keeping yourself safe and healthy, you have to take the medicine. And then if the baby is older enough or can understand about the disease, then I will say it is you have some infection or some germs or some disease. You don't name, because if you name the disease, it might disclose to the friends, might disclose to others, might disclose to neighbors. So they don't know the consequences. They don't have any idea about the disclosure, stigma and all. So don't name the virus as HIV virus. You can say you have some disease. So like I'm wearing specs, I'm having problem in my eyes. Similarly, you have some problem in your body, so you can't see from outside. And for that, you need medicine. You have to take the medicine regularly. As I'm wearing my specs daily, I'm taking medicine for pressure. In that, you can, according to the maturity level, you have to disclose it. And when babies, it is supposed that about 12 years and above, he will be quite understandable, quite mature. He can understand his own illness, own health. Then you can say that you have HIV infection. You should not. And again, of course, don't take it granted that if you disclose, and baby is not going to disclose as he is older enough, 12 years and all. But no, you have to teach the child that don't disclose it to anyone other than your parents. So don't take the medicine outside. Don't take the medicine at home. Don't tell they are taking medicine, because everyone is having their own problem. They are taking they might be taking for medicine for something else. You are taking medicine for something else. You are taking medicine for HIV. They might be taking medicine for other diseases. No one is going to discuss all those things. You are not going to discuss all those things to your friends. So you have to counsel all those things while disclosing fully. So but before doing the full disclosure, you have to understand the maturity level of the child. Next slide, please. So you can give the picture, or you can show the cartoons and show the anything the way you can counsel. Like you see, there is a any cursor. Okay, you can see there is a 3 to 6 years. The face is as if the baby is not well. If you are not well, you won't be able to play. You won't be able to run. You won't be able to do the competition, take part in competition. So you won't get the prizes. You want to take the prize, you have to be strong. You have to be very healthy. In that way, you have to counsel in 3 to 6 years, so that you have to take the medicine to be well. In 6 to 9 years, again, you say you take the medicine because you have an infection. And as I already said, 9 to 12 years, you can say it is some viral infection. Don't name it till he is confident enough to understand. Then only disclose the disease. Next slide, please. Understanding the caregiver's fear and concerns is very important. It's very important because the parents are feeling guilty. Because of me, because of our disease, we made my child positive. It's very important. It's very common, very usual. So it's very important to know their understanding and what they are having problems, because it's very difficult for the parents to say, you have a HIV because of us. It is a vertical transmission. It's very difficult. So you just first understand what is the caregiver's attitude, what is the caregiver's understanding, what is the caregiver's concern, what is the caregiver's fear, how does one give it to get HIV. So all those things, whether they know or they how they want to disclose it, take the permission from the caregivers. You want to disclose just now, or you want to disclose a few months after? So take the decision, see the confidence level of the parents, and then ask them to disclose. And it is better to disclose by the caregivers in presence of health providers. That will give them more confidence to the parents also. So they should know how does one get HIV, what are the treatment options, management, how can diagnose, what are the problems, what are the opportunistic infection can happen, and then what is the importance of taking drug regularly, and it should be taken for lifelong, it should be good adherence. All those things, if there's any doubt, that should be cleared first, then only they disclose to their offspring. Next slide, please. Now you have to explain why it is important to disclose. If they say, no, we are not going to disclose, let it be as such going on peacefully, let them go peacefully. If you disclose, because we have seen many cases after disclosure, especially in adolescents at 12 to 14 years, we have seen the child ran away from the house, came to us, had a psychiatric problem, depression, they had a suicidal ideation. We have seen these patients, they have a suicide. When I asked the parents to take him to the psychiatrist, he said, I'm not going to go with the psychiatrist. I'm not bad. I said, the what is the mobile you have? What is the connection? He said, this is a mobile, some mobile, he said. And what is the network? They said, this is, this is the Geo Ambani. Ambani is the richest person in India. He takes daily counseling. So counseling is not bad. Counseling is not for the mad people. Counseling for anything, how to keep us healthy, keep us good, keep us right. That thing we counsel. So don't worry. We are not going to have a counseling because you are having some neurological problem or psychiatric problem. You need counseling. So you have to counsel your child and their caregivers why they need the psychiatrist opinion or good counseling if there's any suicidal ideation, depression after knowing the HIV status. It's very important to know the status, mental status of the child. If you won't disclose it, what will happen? It may have a baby might get it, might come to know from the others, from the doctors, from the caregiver, the neighbors, or someone else, and that will give more guilt, more aggression, more grievances against their parents. So it's very important to disclose it before they get this sort of behavior from this. So you have to prepare the child for authentic information and avoid unnecessary traumatization, because if you won't say in a proper time, that will cause more harm than to say earlier. It's better to disclose than not to disclose, because if they come to know from other sources, that will be more shocking for them than if this comes from the parents. Next slide, please. Next slide. It's already done. It is already done. What are the other counseling messages? Next slide. So as I already said, not only the drugs, not only the HIV, not only the side effects, adherence, follow-up. So you have to think of the counseling of the issues, different issues. For the issue related to HIV, issue related to nutrition, issue related to immunization, and the future care of the child. I'm not going in between because time is not there. We have to see the adolescent counseling also. So just next slide, please. So counseling for adolescents living with HIV is a very important issue. And we adolescents 10 to 19 years, we say that they are adolescents. And why it's different? Because they are in a rapid growth. There's rapid changes in the physical growth, both external and internal. There are changes in the mental, there's changes in the emotional growth, there's changes in the sexual growth, and the behavioral. So there's lots of changes from the childhood to the adolescent and to adulthood. And this is a changing phase. And there's lots of diversion can happen, and lots of problems can appear if you it's not address the adolescent properly. Next slide, please. Next slide. So there are different type of issues might arise depending upon the mode of transmission. If they are vertically transmitted or if they are horizontally transmitted. Vertically transmitted means they have the infection since birth. That means it will delay their growth, development, nutrition, and there may be increased risk of mortality, morbidity, and mortality. And if it's a horizontally transmitted, that means they are healthy beforehand till they get the infection. So usually the opportunity infections are less likely. They are having normal growth and development, morbidity and mortality quite less depending upon the time of horizontal infection. If horizontal infection acquired at the very early age, again it behaves like mimics like a vertical transmission. But usually if they get it in the older children, then they are already having the normal growth and development, and then the disease is not so severe and the mortality quite good. Next slide, please. Now challenges. What are the challenges faced by the adolescents? First, there's itself adolescent phase is full of challenges, and moreover they are having the HIV infection. So challenges may be due to adolescent phase or of life, and challenges may be due to the HIV infection. So at adolescent challenges due to this phase is because of the, as I said, there's a rapid change and changes in the brain development, cognitive development, emotional development. Because the emotional development, and there is a differential growth of the development of the brain. The frontal lobe develops very slowly and it matures by 24 years. Whereas the limbic system, whereas the emotional fibers are there, it is matured by 14 years. So they are emotionally they're very much emotional, but the judgment, thinking, abstract thinking, and decision making is not that mature because frontal lobe takes the time to mature. So they are over impulsive. They don't think of the consequences. They go for the adventurous action. There's an idea for risk-taking behavior. They are all of the tendency to try something new. These are the common challenges for all the adolescents. They need the identity. They need their own. They want to have their own independence. And this is the stage where they have a more peer dependent, not the parents dependent. They become more peer dependent. They have some self-image. There's different changes because of the external physical appearance. So there's a different attitudes and knowledge about the sex and sexuality. And there are other common problems due to the developmental or hormonal changes. Moreover, they are having the HIV. So there is a challenge due to HIV infection because they are older, not older enough to understand, not younger enough to ignore. So they are having HIV stigma and discrimination. It's a chronic disease. They have to think of that also. Long-term morbidity is there associated. There may be comorbid conditions and there may be socio-economic conditions. Moreover, this is the stage where they have to think of their future. They have to think of the career. And so this is a very challenging phase of human life when they are having an HIV infection. Next slide, please. So what are the challenges? If they have already discussed this slide, particularly infected, there will be a growth failure, developmental failure, pivotal failure. They are usually having short stature, thin build, delayed puberty, and there may be long-term comorbidities may develop. They may develop the non-communicable disease, much more common with this group of children, like the psychiatric disorders, endocrine disorders, obesities. They might have some other challenges like long duration we are including. There may be a faltering of adherence because in the adolescent, lots of activities with their schooling, college, tuition. Then if they are not working in studying in the school, they may have a small, usually engaged in the small sectors for work and all. The timing will be different, so there will be chances of adherence failure quite high, treatment failure quite high in adolescent. That should be the issues should be taken care of while counseling the adolescent. Next slide, please. So they might be living in a very fringy society, hiding their sexuality. There may be problem in occupation or gender. There may be lots of criminalization. They can if they are HIV positive and having high risk behavior, they can indulge in the drug abuse. They can have a sex work. They can be used to that because the common age group for trafficking is 10 to 14 years. So trafficking, for sex trafficking, for the work, for the small slaves of the labor, all those things happen in the adolescent. And even they are having less approach to the healthcare. They are very shy to go to the hospitals. If they are having any STIs, they won't go for the STI clinics. They feel shy. They won't come to the ART center because now they have some monopoly, some independency. They won't listen to the parents and all. There are lots of things. They won't get the condoms. They won't able to buy the condoms or utter the word condoms. They feel shy, and there will be unprotected sex. And then again, there is loss of other infections and all. When there may be a delayed detection because of they are quite growing, eating normal, healthy. So maybe if the HIV is there, then maybe delayed detections, and because of the low index of suspicion, then as they remain asymptomatic for long period, they acquire the infection, especially in adolescent. Nowadays, what we see in adolescent, especially in the male children in our center, is the male to male sex is quite common. So there's all those things can be taken care of while counseling in the adolescents. And there is a chances of loss to follow up quite high in adolescents. Next slide, please. And these are some challenges which will be both for the vertically transmitted infection and horizontally infected adolescents. Both are like the adverse family and social environment, because the adolescent children are the vertically infected or horizontally infected, they are sometimes they are neglected. They are isolated. They are separated from the other family members. So there will social, there may be social separation, stigma. There may be lots of discrimination, difficulty in accepting and learning to cope their diagnosis. They won't realize that they are having HIV. They don't able to understand, don't able to digest that they are having HIV. It's very important in this age group. So if they are positive for since vertically and they're having a low growth failure, developmental failure, they're coming regularly in the ART center, they are acclimatized. But when they get the infection at the horizontally, especially the older children, and suddenly they have to come to the ART center, it's very much traumatic for them. Then higher chances of hindrance during education, career-related challenges, other activities is hampered because they have to come regularly with the ART center, they're taking medications, and there may be opportunistic infections, and that will have a great challenge for their future. Then there will be difficulty in coping relationship, following protected sexual practices, there is the unwanted pregnancy, and they are very common. The increased mortality and morbidity in a teenage pregnancies, teenage mother. Okay, next slide, please. So lots of problems appears in the, especially in the adolescent and pregnancy-related complications, high increased morbidity and mortality in adolescent girl child. So how do you counsel the adolescents? Next slide, please. So there are different aspects of counseling in adolescents. First, the HIV-related counseling. Second is the inherent problem due to adolescent phase. Those are the sex and sexuality. And then the life skill change and modification and counseling about the life skills. And if there's any comorbidities and other issues, career-oriented issues, that's to be also counseled. So first, the care and treatment. The adolescent to be counseled about the understanding the HIV, the importance of taking ART for lifelong, the importance of good adherence. And though they are mature, they can understand the disease, so disclosure is very important. You have to disclose it properly and accurately. There shouldn't be no wrong disclosure. There shouldn't be any. You should not hide anything. You have to clearly explain everything to the adolescent. Otherwise, the consequences may be very bad. So disclosure should be complete. Then a healthy living style. How to you have to counsel about how to live healthy and what are the healthy living style there. Then as the adolescent phase is a quite a rapid growth phase, there's many organs are rapidly growing externally and internally. There's a surge of hormones. So we need extra nutrition. So whatever the nutrition normally children need, they need extra nutrition due to the rapid growth of adolescent phase. Moreover, they need more extra nutrition because they're having HIV infection. So again, moreover, they are always busy. They are less time. They are usually spend maximum time outside the home. They are more prone to develop fascination for junk foods. So all those things, taking care, you have to take care of the counseling about the nutrition. What is the importance of avoiding junk food? Why you should not take the junk food? What are the side effects? Because it's very easily available, and always it is which is available outside the gate of the school, or all the extracurricular swimming pool or other anywhere the young children are there, you will get the all the junk food selling outside the campuses. So easily available, ready to eat, and all those things are very attractive. So they are very much prone to take the junk foods. So all those things to be taken care of while counseling about the nutrition. Then sex and sexuality and about the HIV infection is very important. Growing up with the changing behavior, you have to teach, you have to take the opportunity as they have come for HIV, you have to take the opportunity to counsel what is sex, what is the legal issues about the sex. You have to teach all those things also. What is the legal age of having the sexual relationship? What is the sexuality? Means the ideation of the sexuality, identity, the phenotype or expression of the sex. It's very important to know how to the gender discrimination should not be done. What is the importance of being respect to the others, other genders? All those things to be counseled while counseling the sex and HIV. And of course, how to take, how to have a safe sex, the use of condoms, the barrier methods, and what is the legal age of sexual relationships. All those to be taught. Then how to prevent the pregnancy, especially the teenage girls. We have seen many, still we are getting many cases of teenage pregnancy. So how to prevent the pregnancy in teenage. Then that we can explain, and how far you should not get the pregnant. What is the ideal age of getting pregnancy if they are already married? These things are to be explained by counseling. Then the life skills, again, the communication skills, like a good life skill, having the physical exercise, diet, taking the decision making, planning for the future, career orientations, education, handling how you handle the stigma and discrimination if you face a sort of stigmatization or any discrimination, how you handle all those things to be empowered, because adolescents are very shaky face, and they're very usually they are very introvert. They won't express themselves, they won't open up themselves in front of the others, especially they in front of the doctors or the counselors. So if we have to take the lead too, so that they can open up, as I already said, the gather approach. And when we suspect some drugs abuse or some high risk behavior, we have a HEADS approach, HEADSSSS. So I'm not going in detail because of lack of time, but you can go through the book. The HEADS approach is very important when you suspect there's a drug abuse in the adolescents. Next slide, please. So it's very important to know what to do, what to not to do, or what to avoid. Be truthful, as I already said. He already said you have to say correct and complete information should be given. Be truthful about what you know and what you do not know. Be professional and technically competent. Use words, concepts. So you should not use any jargon, medical jargon. You should use a very simple language, the language which they understand. If you say something like, sometimes we in our state we say the counsel in Hindi, after full sentence we said, then they say, Madam kuch nahi samjha, jara Hindi mein boliye. So that way you have to think which language they have to understand, and in their understanding language have to explain it. You may use the interpreter if you don't know that language for the child adolescents, or you can take the help of the parents or caregivers. You can use these different charts, pictures, or you can explain it in the flip charts by and can give the examples. Because while counseling, you have to explain the different organs, or if you are counseling about sex and sexuality, if you're counseling any disease, you have to draw. You can show them by the future. Treat them with the respect, as I already said. Each and every person needs respect. So always pay respect to them. Give all the information. And let them know first, let them ask, what do you want to know? Ask them, what do you want to know? What is your knowledge about HIV? How do you take the HIV as a disease? So let you understand how much they know. Then you counsel them. Treat all adolescents equally. Don't bias. He is from this status, he is from that status, he is from poor economic status. I'm not going to tell all those things. He is a male, so I'll give him the sexual advice for barrier method and condoms and all. She's a female, we won't ask for the prevention of sex, or how to use the condoms and all. No, they should not indulge in the sex and all. So we should not bias, but we should be legal. We should inform them what is the legal age, what is the legality, what is the punishable act and all. Be understanding and supportive even if you do not approve their behavior. Accept that they may choose to show their own interest. Avoid giving inaccurate information. It's very important. Don't give the half information or inaccurate information. Don't break the confidentiality. First, you say he will talk to you. First, you will explain. He will the adolescent that I'll talk to you. Then I'll call your parents and I'll talk to your parents in front of you. Do you agree with this? So take the consent from the adolescent. So he will say, oh, yeah, okay, you can talk to my parents in presence of me. That way you break the confidentiality. Otherwise, don't break the confidentiality. Giving them only information that you think they will understand. Don't give them a big diagnosis. Don't say medical jargons. All those they don't understand. And they should be very polite and all, telling them that what is the best way you're still on. And again, here also we don't be judgmental. Always take the their attitude, their knowledge, their acceptance as our acceptance. So we don't be judgmental. Oh, he is bad. He is from this family. He is not going to listen to me. So all those things we should avoid. Be very comfortable. And as I said, always follow gather approach. G for greet. A for, again I'm explaining. A for ask, why have you come? What are the things you know? What do you know about the HIV? Ask. T for tell him about the importance of HIV, what is the important taking drug, and adherence, STIs, comorbid infection, comorbid conditions, opportunistic infection. Then H for help. Help them to take the decision. E for explain. And of course, H for you ask for the home environment. E for explain and education. What he is doing. What is the education, whether we're going to school or not. L for listen. And R for gather. R, the last letter R for gather is the return. So if you behave now nicely, if you counsel the adolescent nicely, they will come again. Others, they are not going to come second time. If you behave badly, if you don't listen to them, you don't pay attention to them, they're not going to come second time. So it should be very comfortably, you have to take both the parents and the adolescent together in confidence, and you can do the different type of counseling. You can do the homogeneous counseling. All the adolescent people at the time and talk about the nutrition, diet, sex, sexuality, not. You can do the open type of counseling. So all the parents and adolescents are sitting together. You can talk about the hygiene, nutrition, vaccination, all those things. So you can choose the group of counselings or type of counselings, and you get the important messages about the different issues. Next slide, please. Again, 5As, I'm not going in detail. Again, the same 5As, assess, advise, agree, assist, and arrange. They are all the same. You have to assess their importance, their knowledge, why they have come, how much they know, all those things. Agree, advise them. Then again, agree according to their need, their choice, their options. Assist to take their drugs and arrange for all the investigations, and medications, any other care. Even sometimes we might assist them or arrange them their counseling better. They need some career counseling. They are in 18, they have passed 12, and they have come to you, and they take the help, because they now they're coming for last 5 or 6 years. If they are having infection in the horizontal, if they are having an infection from vertical transmission, they have a good rapport with the ART people. What we see in our center also, there's a good rapport with the ART people. They will very friendly with the other ART staffs. So they might come for this time. I have passed 12, now what to do? Give me the career counseling. So you have to arrange where they will get the career counseling, where they get the other counseling. So these things should be also added in case of HIV with the adolescents. Next slide, please. This I'm not going to tell you. So next slide. Again, advice of the treatment is already discussed about the treatment plan, the adherence to the importance of taking drugs regularly, compliance, all those things. Next slide, please. And this is already discussed. Agree, assist, and arrange. Assist, as I said already, have to assist for where to get, they will get the condoms, where if they want to take the condoms, where to get the iron and folic acid, where to get the vaccines, because everywhere now adolescents are avoided or neglected. If you go in a pediatric department, they are taking care of the first pediatric patient, then they will get the adolescent. If they go in the adult medicine department, first the medicine people, adult people will be taken care of than the adolescents, and they are very shy, so they don't go second time. They won't go to the. They won't be open up. They might go for some STIs, but they won't be able to explain their problems. These are issues are there. So you have to arrange, you give some caregiver assistant so that they can help to get the proper treatment, proper care from different sources. And assist them with the both physical, mental, and social well-being, because this is a very important issue of the adolescents. Sometimes they might need the counseling from the experts like counselors or from the trained psychologists. Next slide. You can arrange as already discussed referral for group counseling. As I said already, you can have a referral for group counseling. You can do the counseling different groups. You can have a homogeneous group, means only the boys. You can have a counseling to only the girls. You can talk with the menstrual issues and all that menstrual hygiene to the girls. You can talk to the other things in the boys. Again, you can have heterogeneous group. Both the boys and girls can discuss about the nutrition, vaccination, the career counseling, legal issues. And you can have an open group counseling, like both the parents and the other positive children and adolescents, where you can discuss the common things. So you can arrange the group counseling, a different type of counseling depending upon the need of the adolescents. Next slide, please. Disclosure is a very important issue. Next slide, please. Because we have to disclose it totally, fully, and correctly, because that is a very important issue, and you cannot deny anything, cannot hide anything. And moreover, when you disclose, there might be some reaction. There may be quick reaction. There may be some reaction to rejection. We have seen sometimes there is a depression, there may be aggression. So all those things you have to be very apprehend beforehand. If he will be depressed, how will you counsel him? If he is aggressive, how will you tackle him? So all these things are very important. You have to have a good group to take care of those things while disclosing. So also improves the, if you disclose, then he knows that he's having HIV, he has to take the ART for adherence, for lifelong. I should be good adherence. Then I think the retention and the care and the adherence will be good. If he knows this disease and if he knows the consequences of not taking medicine, that will help him to be on care. So retention will also improve. Disclosure could be, and again, in so all the adolescents not having the same maturity level again. So you have to understand, because we have seen many adolescents are very mature in the early, the adolescents have 3 phases, 9 to 14, 13, 14 to 16, and 17 to 19. The 3 phases. We say early adolescent, mid-adolescent, and late adolescent. Early adolescent, sometimes such children are in early adolescent, though they are in the late adolescent, they behave like a child. And sometimes they are the mid-adolescents or early adolescents, they behave like an adult. So maturity level may not be same in all individual adolescents. You have to take care of their maturity level. And according to that maturity, you have to disclose. So not all adolescents taken as a granted, and the very first day we are going to disclose everything. So gradually have to tailor disclosures to be done to them. And always manage the barriers to disclosures. What are the barriers? Why you are not able to, the parents are not able to disclose? All those things already explained, and that should be taken care of while dealing with the adolescent. It's very important to take the help of counselors. The parents are not able to disclose. Always ask the parents to come here, up to the ART center. In presence of us, will help you to disclose. So you disclose yourself, that will give more respect. The parents disclose it, it will pay more respect to their kids. It's very important the adolescents be disclosed in presence of counselors in the ART center by the parents. So, next slide, please. So I think this was the last slide. So counseling in the adolescents is a very challenging issue for both the caregivers, doctors, and the counselors, and of course for the it's a very important issue for the caregivers who are having adolescents. They know what is the difficulty for bringing up the child as adolescent without having HIV. So if he is the adolescent having HIV, it's a double-edged problem. So that should be taken very sympathetically and very empathetically. Thank you for patience hearing. If you have any queries, you can ask me. I'll love to answer.
Thank you so much, ma'am. Sorry, it was a lengthy session. Sorry,
Yeah.
participants too. Can we quickly take questions from the participants, please? Kiran, can you please unmute the participants? Participants can now unmute themselves and ask questions if they have anything related to counseling of children and adolescents living with HIV. Ma'am, I don't think there are any questions. Thank you so much, ma'am. Thank you for your time.
Thank you.
We'll quickly run through the post-test, ma'am.
Yes,
Kiran, can we have the post-test, please? Kiran sir, can we have the post-test, please?
Not here.
Okay. The post-test is now visible on your screen. There are 6 questions in all. Please scroll through the questions and answer all the 6 questions. Requesting participants to wait for another 5 minutes. We also have the feedback questions after post-test. Kiran sir, we can end the post-test and move to the feedback questions, please. We can end the feedback poll. Thank you to all the participants for patient listening. Thank you to Puri sir, NACO, Anju ma'am, KSCH, and Kalpana ma'am from MCA, pCoE, MCH. Thank you to all the participants for patiently being there till the end of the session. Ma'am, can we end the session now?
Yes, yes. Thank you.
Thank you so much, ma'am. Thank you.
Ji. Question के answer.
Post test. Yeah, give me 2 minutes, please. Yeah. Answers to the pre and post test questions. Which of the following statements regarding classification of nutritional status of HIV infected children between 0 to 14 is true? The answer is weight for height, that is BMI for children more than 5 years of age and less than -3 Z score, or MUAC less than 115 mm in children 6 to 60 months is categorized under severe nutrition. Which of the following is true regarding management of SAM in CLHIV? All of the above, that is, they require 50 to 100% extra energy every day. Extra energy is required for the period of 6 to 10 weeks, and children with SAM without medical complications may be managed at home if they still have a good appetite. Question number 3, which of the following shouldn't be a part of child-centric counseling for CLHIV? The answer is tailor-made approach to trace the root of HIV transition in child and disclosing it to the child shouldn't be part of the child-centric counseling. What is partial disclosure? Partial disclosure is defined as when the child is aware that he or she or the parents have a chronic illness and is taking medications for it. What are the characteristics such as partial or non-disclosure of HIV status, higher mortality rate, likely to be in advanced HIV, are best described by which of the following group of the ALHIV? All these characteristics are likely to be in the vertically infected adolescents. The last question, following points are to be avoided while communication with the adolescent living with HIV. Except which point, that is, be truthful about what you know and what you do not know. So except the other three, one has to be truthful about what you know and what you do not know. That's all. Thank you. The next session is on 17th of August. And the topic is HIV and opportunistic infections, central nervous system.